Hey guys, welcome back. So today is the day that you didn't know you were waiting for, I think. This is usually the week when all of you therapists, mental health counselors, and people who aren't therapists and mental health counselors but have to deal with therapists or make diagnoses or any of that kind of stuff. This is what we're going to be talking about today. Is typically diagnostics. When we talk about assessment, again, just as a reminder, I'm going to probably do this a lot through the class, and we're about halfway through now. So if you're not used to it already, I'm just going to reorient us constantly to this idea that when we're doing assessment, we're thinking about what are the expectations from us to communicate whatever we're doing in therapy to other people outside of our therapeutic room or our counseling space. And what are we actually doing with our clients? Because there can be a whole bunch of overlap, but there can also be some differences. And many of us, especially if we come from that humanistic tradition, we don't necessarily think of diagnostics or what goes on in the medical world as part of what we do for our therapeutic work. Some people come in and are clearly experiencing some symptoms, and talking about diagnoses can be really helpful. Other people just want to deal with their life stressors and don't really know if there's a clinical condition or don't want there to be, or it's not part of the experience of helping them through a marriage or an argument with a colleague or trouble with their kids or any of those kind of normal life things. Remember, counseling is about wellness for everyday conditions like grief and loss and heartbreak and that kind of stuff. So today we're going to talk mostly in the context of that clinical assessment, meaning diagnosis, and a lot of DSM related stuff, okay? I'm going to try and do my best to give some examples of stories of how you collect information from somebody who isn't really coming in for a diagnosis, or you're thinking, I have to make a diagnosis for billing purposes, but the content of what we discuss is really not about symptoms all that much, and it's not really about a potential diagnosis for them. So this is where a lot of people get really confused when they're learning how to make an assessment or do assessments, particularly diagnostic ones, is how do I derail somebody from the story they're telling me about their life to ask them about symptomology? Or if they're asking me for specific information related to symptomology, how do I go about digging that information out or gleaning it from whatever they're telling me? So I'll kind of cross over into that territory too. Just to let you know now, I'm probably going to stop this recording a little bit short and skip over to a different one. And there'll be two recordings that are kind of part of this to talk about mini mental status exams, because I have a bunch of other things I want to bring up and show you, but that'll probably be a separate video, not quite as long though. So anyway, without further ado, let's jump into it. Oh yeah, by the way, that's me. I don't know why I'm telling you that, but I felt the need to because I just changed it. So whatever, who cares? Okay, so fundamentals. Let's just kind of start this at the very beginning. Remember the purpose. What we're trying to do here for clinical assessment is to accurately understand what the problem is so we can choose the right decisions or treatments or potential outcomes, that kind of stuff. So to take the analogy that we used at the very beginning of class, if somebody comes in with a broken arm and we send them home with cough medicine, we've done an improper diagnosis, so we've used the wrong treatment for the condition that they have, okay? The whole point of using this diagnostic, what's the right term, system, I guess, and all of these diagnostic tools, assessment tools, is to understand what is actually going on so that we can have some common language for the whole profession, the whole field, and the payers and the administrators and everybody else, so we can talk the same talk, have the same common language. So that's what we're trying to really do, is understand what are the conditions that are normal for people to have, and we base that on symptomology, or at least the medical model does, and then we give a diagnosis. So that's the purpose of what we're trying to go for here. There are, it's not a straightforward process, it never has been, and it continually evolves as versions of the DSM evolve and culture evolves and all that kind of stuff as we get better science. But there are some political issues as well. One of them is licensure parity. Sometimes you'll hear that term licensure parity, and it's almost sounds kind of like old news now because we've gone through COVID, and on the other side of COVID, the Counseling Compact really gained traction, and now many states, not all states, and I'm not going to show you here, but if you go to counselingcompact.org, I think that's the website, you can see which states are part of the compact. What the compact means, if you haven't heard or you don't know, it means that states have, they will acknowledge that you have a license in another state and make it easier to transfer your license or get a different license to treat people in a separate state. Used to be that every state had their own rules, they functioned separately. Not to get into a whole lesson on politics, but states' rights versus federal rights, it would seem so nice if there were one process and everybody had to meet the same criteria to get licensed in any state. But that's not how government works. And as we move potentially more back to states' rights and being able to choose how their constituents need to be served, that's how counseling has worked for so long. However, in medicine and psychology, they've had sort of universal across all 50 states, the same criteria. Don't quote me on that because I don't know how that works for those professions. But what the compact is trying to make all states require the same thing, or at least acknowledge that if you've been licensed in one state, that can easily transfer over if you just follow all the same rules and go through a different application process. But we don't have to go dig back through your educational requirements and whether you've met hours and all that kind of stuff. The reason that's in this lecture is because there are some states, New York being one of them, for example, where you can't diagnose. Psychologists and social workers and other mental health professionals in that field, there's a little bit more politics going on. And because of that, psychologists can diagnose, so counselors cannot. They haven't earned the right to, the laws state that counselors can't diagnose in those states, which kind of complicates this whole issue of, well, can't counselors do diagnoses in every state? Well, not really. So that's some of the politics that we're getting sorted out here. But I'm not going to go deep into that, but just so you know that that exists. The reason that exists is because, well, I guess I am going to go a little deeper because it's up here. But the reason that exists is a question of competence. How well are you trained? I'll ask this question, understanding full well that this is a video that's going to be on YouTube publicly. Not that anybody's watching it except for you guys, but, you know, just in case. It's the issue of competence. How competent do you feel to understand this book, understand this diagnostic system, and then being able to, with experience and practice, be able to accurately make those diagnoses? The understanding is, or the expectation is, that you learn this stuff at a fundamental level. You'll get this class in assessment, another class in diagnosis, and really learning the DSM and these different conditions, and then be able to go out there and understand how to use it to make accurate diagnoses. But there are lots of questions on whether we can do that, whether we should do that. And again, many of you are here to learn about, I don't know, like just different kinds of stuff. You'll get really into internal family systems, which is not even really a counseling focused system of theory, I guess you could call it. Or you'll get into, I don't know, really person-centered kind of work. Your theory will be that person-centered kind of work. That's how you'll practice. And you're not necessarily going in looking for symptomology, but you're looking for what are those areas in a person that are not that are stubbornly rigid, or not, where they're not ready to change or something like that. There's all kinds of different systems for what you might be assessing for. Stages of change, defense mechanisms, if you're kind of a psychoanalytic spin, interpersonal family rules or mores or norms or something like that. So depending on the kind of approach you're taking, you may or may not be looking for symptomology. So if that's what we're teaching in programs like this, how ready are you? And that's the question that other people are asking. Well, if you're not competent enough to do this, if you don't have enough practice, or that's not what you're trying to do anyway, then why do it? That's kind of the rationale for it. So with that said, you are taking these classes and then you're doing internships and you're getting practice out in the field so that you can be ready to do this, but you aren't expected to be able to be competent in it right now. So if you're watching this video, you're in a program and you're like, I don't know, this seems like a lot of stuff and a lot of responsibility. It's because it is, and it should be. And you may not be ready yet, but that's okay, because that's what we're here to learn right now. And then I think for the third point here, you can kind of get a picture of this power struggle between these separate professions based on this competence and state laws. And so there's a lot of politics that go into it. I'm not going to go into it now, but there it is. The point of these initial assessment interviews is to determine the need for further testing. So in other lectures or in class, we've had this discussion about a person maybe calls in, talks to somebody on the phone and says, well, I'm kind of here because I'm having a hard time at work. My boss is stressing me out. And so I just want to talk to somebody about it. So they put, work stress, whatever. When I think work stress, I immediately sort of filter out some kinds of diagnoses. I'm not really thinking about neurological disorders. Not thinking about any of the adolescent or childhood disorders. I'm kind of filtering through this decision tree of what are the potential DSM diagnoses, and thinking what are possible. And the more questions I ask, and the more I meet a person, like when they come in for their first session with me, we go through informed consent, kind of get the official stuff out of the way, and then the person says, well, I have such a hard time sleeping, and every Sunday night I get kind of nervous before work, kind of the Sunday scaries. And I just, I can't sleep and I worry all the time. And so I'm hearing all of this and I'm thinking, oh, this is really pointing to the common condition of anxiety or something like that. But I may have a hunch, but I may not know that. So then I say, well, I have this questionnaire. Do you mind if I grab it real quick? And we pull out something I'm going to show you in a little bit. And I say, can we just walk through this and talk about some of these symptoms and see if any of these sound like they are relevant to you, or they're part of your experience. So what I've done is I take their initial phone call to set up the appointment in our first few minutes to determine the need for further testing. It's not always that easy. Most of the time, well, I shouldn't say most, but a good portion of the time, if people are coming in for depression, anxiety, which is most people have some version of that, not everybody, but a lot of people do. Then I'm deciding, well, is it just anxiety? Is it just depression? By the way, there's not just anxiety and depression. It's major depressive disorder or something like generalized anxiety disorder, or it could be social anxiety. And there's a lot of other actual diagnoses. But when I'm thinking about it, I'm just sort of thinking in these broad stroke categories. And then I want to whittle down to a more refined understanding of what is the actual condition this person might be experiencing. So what do I want to say about number 4 here? Assessment in the DSM. I think we've talked about this enough probably in class for most of us, maybe, that not all assessments are directly aligned with the DSM. In other words, they're not assessing for the specific symptomology of a specific condition. So we can't get all of the information we need from all assessments. It really kind of depends. So that's where some of the reservation about, well, these tools really work. Are they really supposed to give us a diagnosis? Well, they can get us closer to an understanding, but they can't tell us everything. It's like saying there's one intelligence assessment that captures everything you need to know about the inside of a brain, which seems silly even just saying it, right? So what you do is you use several different ones, because this one captures this thing, this one does this other thing, and together it gives you a more robust understanding of what might be going on with somebody's memory and object relations and all these different things that we're trying to assess for. So it's not a one-to-one match between what's in the DSM and what we're seeing on the assessment, but they give us another helpful tool to get that information. So some of it is the story that a person tells verbally. Some of it is your questioning that you informally just start asking about different kinds of things, about sleep and diet and motivation and that kind of stuff. And some of it is specific to the DSM, but that's where it takes a full picture from interview and our experience, and then different tools potentially. And then the last one here, this number 5. Oh yeah, I have to get my hat out of the way. Got to remember to do that. The last one for number 5 here is that the DSM is basically the American version of a mental health diagnostic system, but it's not the one that the whole world uses. Much of the world doesn't acknowledge the DSM. I don't have any, I don't know how many other countries or who else might use it or may not use it. But the ICD-11, sorry, the 11 is out now, the International Classification of Disease. This is what most of the world uses. It includes medical conditions, or I should say physical conditions, physiological conditions, as well as mental or psychological conditions. Doesn't have quite as many as the DSM. They're not all the same, but it's kind of this attempt to say universally or globally, this is our understanding of mental and physical conditions. We are learning the DSM. That's the one that you're going to be responsible for testing purposes. So we don't really go over the ICD-11 very much, but it's just another coding system you should be aware of. Some places will use the ICD along with the DSM. Some places will use the DSM only. So just kind of log that acronym away in your brain and know that it's not the only one. In other words, America's not the center of the universe. It may seem like that way. We might have this sort of ethnocentric or Eurocentric version of mental diagnostics or whatever, but that's not the case. So it's a bigger world out there. I'm gonna pull my, I'm gonna pull this over just a little bit so I can make sure it's not in the way. My speech to text transcription software thing, whatever. Let's talk about the pros and cons of clinical assessment. There are more than this, but this is kind of what's in our textbook. So if you're following along with that, this is what I've gleaned out of that. By the way, I'm going to try and move through this pretty quickly and get to the other actual conditions. It's what I really want to get to talk about. For example, there used to be a separate diagnostic category for autism and Asperger's disorder, but there isn't anymore, and now it's on a spectrum. The point of that is that we tend to talk about autism as if it's like this high functioning versus low functioning, and even then, I think the spectrum, the way we're using it now, is this autism spectrum disorder. I think it has challenges with pathologizing common phenomena. In other words, people say, I might be on the autism spectrum, or I have autistic tendencies, and I hear more and more of that kind of language. Same thing with OCD, with depression, with anxiety. I hear more and more people, and you guys do too. If you're on TikTok or Instagram and you follow influencers or whatever, you hear a lot of people use this kind of language of like, oh my gosh, I'm being OCD right now, or whatever. And the risk of that is that it pathologizes normal phenomena. In other words, I don't know, it's like saying, oh, I just coughed, I probably have a cold. Well, no, your body coughs when it has to get things out of your lungs. It's a normal function. It doesn't mean there's something really wrong. There's not a virus or a sickness that you have. It's just a normal function. Same thing with depression. If you're feeling unmotivated because there's some stressors in your life, so it might just be that you had a long week at work and you need a break. And then after the break, you feel better, right? But lack of motivation or eating more or sleeping more or something, those are normal things that happen, but they have to reach a certain threshold or a certain degree. So we want to be careful about how we diagnose that somebody actually reaches the threshold level of this is causing dysfunction in a person's life to a specific level. So there's been a little bit of that, like how much is how severe or how frequent enough of symptoms count as a clinical disorder. That's where research comes in. I'm not an expert in where those diagnoses fall in those categories, but nevertheless, that trend towards pathologizing common phenomena is something that we have to be careful of. The use of adjustment disorders. If you've been out in the clinical world at all, you'll hear people say, the DSM's stupid. We don't like to use it. We have to put something for billing purposes, but we don't want to give people labels that are pathologizing. It just doesn't really fit the way we understand what people attend counseling for. But we have to get paid, so just call everything an adjustment disorder and call it a day. And that causes problems, right? On one hand, I can understand why people do it, and I'm sympathetic to frustrations with the medical system. On the other hand, it totally undermines the whole attempt to try and have common language based on something objective. So I don't want to get into any kind of debate here because I see both sides and I'm not going to give you an opinion. I'm going to leave you with that and say, here's what you need to reconcile. Best case scenario, you don't pick side. Well, okay, this is my opinion, I guess. Best case scenario, you don't pick sides and you say, I see the need to have this common language to discuss common symptomology so that we don't so that we can get better at really understanding people. And yet I also see that it's an imperfect system. And so I sometimes will have to use, put a round peg in or a square peg in a round hole. In other words, it doesn't totally fit a certain diagnostic category. So I have to use adjustment disorder for certain conditions that are causing issues in people's lives. But what you don't want to do is you don't want to just say, well, whatever, just call it an adjustment disorder because it doesn't really fit. And I don't want to work hard to figure out if it does. That's what you want to be careful of. Are you putting in a good faith effort to make an accurate diagnosis? And if not, if it doesn't fit a specific category, then adjustment disorders are possibilities. And yet we don't want to overdo it. Okay. So I'm just going to leave you with that and let you have those discussions with your supervisors later on. I've said this before in class, but I think it was Albert Ellis. Somebody might correct me on that if they hear otherwise, but I read in a textbook when I was in school that Albert Ellis called the DSM the big book of unhappiness, because nothing happy comes out of there. It's all bad symptoms and diseases and dysfunctions and et cetera, right? So that's what it's made for. That's the intent of it. So the diagnostic system emphasizes pathology, and that doesn't feel good to a lot of us. Just because it doesn't feel good doesn't mean it's important or it's doing something wrong. That's something we should talk about or kind of consider for yourself. Is everybody perfect? And if not, are there ways to pinpoint what is not working so that people can make progress or make change or get better or something like that? We do need to talk about pathology, and we do need to have the capacity to give people hard or potentially critical or negative feedback about something that's going on in their lives. So it could be more about us and we're just too scared to tell anybody something's wrong, or it could mean that, I don't know, it could mean something else. I forgot what I was going to say exactly, but we have to be careful why we're making decisions to either use or not use this clinical assessment system. So whatever. Diagnoses can be used to deny treatment. What does that mean? Trying to think of how I've used that in the past. Sometimes, here's an example. Sometimes, if you think a person has a diagnosis that is too hard, too difficult, too, it triggers one of your biases. It could mean that you're like, well, I don't do good with personality disorders. I really want to, but it's really hard. And I don't know what to do here, so I'm just gonna, send them off to somewhere else. It's too difficult, right? If there's somebody with a neurological disorder who we clearly as counselors don't treat neurological disorders, that's territory for neurologists, right? Like things like amnesia is probably not something we can do a whole lot of help with. Although I will say that there are still potential treatments. There's a place for counseling with people with amnesia, people with Alzheimer's, that kind of stuff. So I'm not saying that we can't treat that specifically. I'm saying there's a question about what's our role there. But how we make referrals and how we make diagnoses is something that we need to get practiced on. So if there's something within our scope or outside of our scope, that's something we need to be mindful of. Also, I don't know if this really fits with this this point here, but diagnosis can be used to either, sometimes we use it as a power tool, which I have thoughts about, but I'll leave that for a discussion in class. In other words, if I want to advocate for somebody, I'll give them a diagnosis so they can get benefits because I really want everybody to have government benefits, or they can get special education services because I really want them to fit this category so they can get this extra help, even if that category doesn't fit. So, for example, like, somebody's has a potential learning disability, but if I just give them a diagnosis of anxiety, then there's a potential that we could get some more attention from other administrators. In other words, we're using it as a weapon, and that's not what we want to do at all. So it's kind of the flip side of be used to deny treatment. It can also be used to get treatment, and both are kind of inappropriate. So the medical model versus the social model, or the wellness philosophy in counseling. I think we've talked about that elsewhere enough, so I'm gonna skip over that one for now. We can bring it up in class if you have questions. If you're like, what the heck even is that? Then let's talk about it. Of course, labeling. Most of us understand stereotypes. There's so much to talk about with this one in terms of how it affects people to have a diagnosis or potential diagnoses. But I'm going to leave that one for a discussion. Labels can be wonderful and life-changing because people can sometimes say, nobody in my family believes me. And now finally there's a condition that I can say, this is what I am experiencing. And now I can find resources and find other people that understand me and that kind of stuff. So it can be a wonderful thing for people. It can also be a very harmful thing, and it can be a detrimental thing. So how we use these diagnoses, sometimes people again, weaponize them or use them inappropriately. So we have to be careful of that. Just for example, recently someone said something along the lines of, given the state of the country right now, given the kind of political things that are going on, many of the clients, let's just say, for example, we live in a largely Hispanic area, or have plenty of Hispanic people. There's a lot of people that are very afraid of deportation, potential deportation, or afraid for family or loved ones or whatever it is. So I've been hearing more rumblings of, well, we're not going to use a diagnosis, and we're not going to put them in our system, and we're not going to bill for anything. We're just going to provide cash pay services only because we don't want them to be on any kind of radar to potentially negatively impact them. So there is a whole ethical conversation here in terms of, if you're a part of a system like this diagnostic system, which you can't separate that really from billing systems and political systems and all that stuff, how do you reconcile this issue that we have? There's a whole ethical conversation to have there, and there's probably some really interesting, I don't know if debates is the right word, but conversations, maybe debates, about what the right thing is to do there. If we're here to help people and the way we function negatively impacts people, then do we continue working like we're working, or do we need to change ourselves, or do we need to advocate to make change in the environment around our clients? There's a whole discussion to be had there, but we're not going to have that. But there's just a whole lot to unpack here with labeling. I've already mentioned sort of the pros of this diagnostic system. I'll just add that it legitimizes conditions. In other words, it makes them from this thing that people experience, they're not really sure what it is or if it's like an actual thing, to an actual thing, so we can talk about them. And then also decide what needs to be treated and what doesn't, which parts are normal and which parts are abnormal. That kind of conversation is helpful. And then, of course, severity. When we talk about diagnoses, we talk generally in I think almost all cases in the DSM, we're talking about the frequency of symptoms and the intensity of symptoms. There's some other words, like basically just how often and how bad is it. So the severity index of, is it, on a scale of 1 to 10, how bad is it? How impactful on your life? How much does it impede functioning? That kind of stuff. That can really give us an assistant in treatment planning. So more to say on that, but just for the sake of time, I'm going to skip that one a little bit. Okay, the question then, skipping back a little bit, when we're talking about this decision tree and understanding what conditions do we know this person has and what do they clearly not have, and as we're sort of working this, chiseling away and narrowing down to one potential diagnosis or two differential diagnoses or something like that, what tools do we need to use? Okay, this is one of the big questions. And we said earlier, not all tools are good for all. They don't match. There's not a one-to-one correlation with our diagnostic symptomology or something. So how do we know? How do we know which one is useful? First of all, it depends on what conditions you need support in understanding. So if somebody comes in and says, yeah, I have this weird relationship with food, then I think that gives us a good idea. We should probably look at eating disorders. We want some help understanding that. If somebody says, I have this funny habit that I'm just not really sure if it's just a kink or if it's a sexual dysfunction, but it's getting in the way of my marriage. Well, is there a diagnostic category for that kind of stuff? Well, this is what we have to try and decide. We find tools that help fit our understanding. Whether it's a diagnostic category or not, we're looking for something just to aid our understanding of whatever a person is experiencing. So let's see. Number 2, for a broad or narrow focus from general condition to specific diagnosis, see page 348. I don't actually remember what's on through page 348. In my book, if I can see it really quickly here on my shelf, I'll grab it. Yeah, hold on a sec. Okay. I should probably know this off the top of my head, but I don't, and that's okay. One thing that I've said in class to some classes is that you don't have to know everything all the time. When I go into the doctor and I say, hey, I have this condition, sometimes if it's a simple thing, they're like, oh yeah, I've heard of this before. Sometimes they go out and they say, well, give me a sec here. Let me go, check on something. And they go out and they go out and Google, they go to WebMD or something, the same thing I do. Because I've talked to doctors about this, and sometimes I've done it with one doctor. We've looked on the internet together, which was kind of fun. But you don't have to memorize everything, just so you know. Oh, that's what it was. Okay, so this is the page I'm referencing here. See if I can get you that's really hard to see. But on page 348, if you haven't already found it, there's a list of some common tools for common conditions right there. I'm not going to go through that, but if you need to look at that for future projects or whatever, you can do that. Or we'll bring it up in class or something. Again, here, number 3 is, here are a few commonly used tools for different kinds of things, different kinds of conditions. The symptom checklist 90, if you don't really know what kind of condition a person may be experiencing, this is kind of like an initial way to get symptomology for different kinds of conditions. Sometimes people use this one too, like even if a person comes in, you're like, well, what you're telling me is depression, or what you're telling me is anxiety. This is also a way to capture things that you may not just capture in a first glance. So if you're like, I just want to rule out other potential things, or I want to make sure that I'm understanding all of these different things. Sometimes our clients don't really know what to report. They don't know what they don't know. So they don't know to share that, I've been having all this kind of tummy stuff too. Because if you don't ask for it, if you're just thinking what's going on in our psyche or our psychological space, but if we don't ask about how's your sleep and how's your memory and how's your, how do you feel in your body sometimes and that kind of stuff, we may miss stuff. So that this SCL 90 can be a great way to gather more of that sort of wider scope of information. EDI, I think, stands for Eating Disorder Inventory. I could be wrong about that one, but just another example. Post-traumatic stress diagnostic scale. There are multiple different sort of trauma scales. Some of them fit PTSD diagnostic categories. One of them that we didn't use in class, but I have used in previous years, is called the CAPS-5. It's used as a sort of semi-structured interview to help you walk through how to do a really thorough trauma assessment. Specifically, does this person have PTSD, as it says in the DSM, or do they not? And that's kind of what that one's for. But this is, I think, a smaller version. The SASI is a substance use scale, although you can get some interesting other information on sort of, mental health conditions, legal challenges, that kind of stuff, to get a more full picture of a person's substance use or drug use or other addiction, chemical dependency kind of things. And then suicide risk assessment, we've covered that in class, so I'll skip over that one for now. The big one, though, is the cross-cutting measures of the DSM. And I'm actually going to click on this one and pull it up here. Basically, what this tool does is, if you look in, I don't remember what page it is off the top of my head, but if you look in the back of the DSM-5 or the DSM-5 TR, there's a whole chapter on assessment. And the American Psychiatric Association, who publishes the DSM, they have this sort of system to say, how do we then do that sort of decision tree, that filtering down process? So what they came up with is this. They call it the cross-cutting measures. And let me pull this up here. Where'd it go? Oh, it was behind a menu. So what they have is this. Essentially what you do is you look at, do you have this is really hard to see. Let me zoom in just a little bit more. Zoom way in. A little harder to navigate, but that's okay. You can see it better. So they have an initial tool, and then based on the outcomes of the initial tool, level 1, then you move on to level 2 to get more refined information. So here's an example. Here's an adult version, here's a child version, and here's an adolescent version. What we're doing here, let me click on the adult version and see if I can get a PDF to come up. Save it. Don't look at my computer. No, I'm kidding. You can look at whatever you want. If I didn't want you to look, I wouldn't do that. Where'd you go now? Okay, we'll get it to come up. Here's what it looks like. I just want to show you the tool so you can kind of see it. For those of you that don't know, if you're watching this for class, we'll probably pull it up in class and use this a little bit somehow. But it has a lot of information on, do you have little interest and pleasure doing things? As people who are kind of in this work already, we probably are getting a sense of where this is hinting. Are you feeling nervous or anxious? You might get a different sense of a different potential diagnosis of where that could lead, or the different several diagnoses. Feeling detached or distant from yourself, your body, physical surroundings, or your memories, sort of dissociative-like things, which could lead to diagnoses like PTSD or potential other things, psychoses or that kind of stuff maybe. So it's supposed to be sort of this high-level understanding of what potential categories are we looking here. In other words, if you were to break it down another way, which chapters in the DSM should I go to? Am I looking at trauma inventories, anxiety disorders, mood disorders, etc.? So that's the purpose of it. Once you have the outcomes of that and you understand how they score on level 1, then you can go on to say, well, there's a more refined or specific diagnosis for these different conditions, from depression, anger, mania, anxiety. I'm not going to download those right now and pull them up. You can do that if you want to. If you need to find this page, by the way, just do like cross-cutting measures, APA, and usually it's like the first link on Google. So it shouldn't be too hard to find. You should get familiar with where to find it too, so you can use this in practice. Level 2 includes assessments for adults, assessments for parents of young children, which they're probably filling out that level 1 too. Adolescence, so sleep disturbances, anger, irritability, etc. So this is something you're likely going to be visiting and revisiting quite a bit if you're in a job where you're making diagnoses. So just so you know. And if you're, for example, a school counselor and you don't really make diagnoses, or if you're a rehab counselor and you're not in a position where you're doing diagnostics at all, some of these can still be pretty helpful in terms of like, you get someone who's just a crabby, grumpy, irritable, angry kid or client, consumer, customer, whatever you want to call them. Pulling out these things can also help you understand what that means and what kinds of things to look at and what things might be impeding, for example, their educational experience or their vocational potential or something like that. So even if you're not specifically making a diagnosis, some of these can be kind of helpful. You guys can look through this. We'll probably play around with this a little bit later. I just want to draw specific attention to this, the WHODAS, or the World Health Organization Disability. What's the A stand for? I'm blanking on it. It probably says it right here on the screen somewhere, but I don't know. But this is essentially trying to capture the functional limitations to make a diagnosis of disability. It's different than a mental health diagnosis. It's one thing to say you have this condition. It's a whole other thing to say, and here's how it impacts your life or impedes your ability to function. So this is specific from my rehab training, but it's probably helpful for you mental health therapists to understand this too. If somebody has anxiety and they're asking you to give me this diagnosis so I can go apply for these benefits, this also is another way to give more information on, and here's what this means for your life. In other words, here's how this functionally limits your ability to perform daily tasks, that kind of stuff. We won't go into this too deeply for the sake of this class, but activities of daily livings, depending on the kind of disability a person has, assessing for activities of daily living might be helpful with mental health conditions like depression, for example, or anxiety. if a person is not getting out of bed and they're not showering, they're not brushing their teeth, they're not able to drive, they're too anxious to get on a bus, these things can impede a person's ability to work, to build social relationships, that kind of stuff. So these kind of measures can help kind of give you another layer of understanding personal and social impact, something like that. So anyway, I'm not going to dig through this too deeply. There's a lot here to go through, but I just want to make you aware of this, and then we can experiment with some of these different things in class and projects and stuff. So let's get back to our slides here. Where are we at? 40 minutes? All right. I think I need to speed up, but isn't that always the case? I need to slow down how fast I talk and speed up how much I can cover. It's kind of competing forces here. I'm going to skip over this asterisk comment here. If you want to ask about it in class, we can have a chat about that. Mini mental status exam. Like I said, I'm going to go over this in a different video, but these are generic categories that you'll see in most mini mental status exams. I'll leave these here and I'll either come back to it or just kind of make a mental note of this and you can look back on it on your own. If you're not going to go look at that other lecture, the mini mental status exam essentially is if I only have a short period and I'm taking a mental snapshot of what is happening in this small period of a couple minutes that I have with the person, what information can I glean from them by observation? What does their appearance look like? What does their behavior look like? Are they really slumped over in their chair? And sometimes, to use some big fancy words, do they display psychomotor retardation? It's a kind of an old phrase, not really PC anymore. But psychomotor retardation just means they're not moving. They're not really moving quickly. You might say they're slowed down or have depressed activity or something like that. They're just not really very expressive. Contrast that to psychomotor agitation, in which they're bouncing around, they're kind of fidgety, they're chewing their nails, and they're, touching their face and their hair, and they're just kind of busy, right? That can give you some information about how they present. Somebody presents that way one week and then comes in and presents with kind of depressed affect or something. You might think, well, maybe there was some mania and depression going on, which, hint, hint, might lead to a certain kind of diagnosis. Hint, hint, right? So attitude towards examiner, hostility, distrust, etc., mood and affect, speech, perceptual disturbances. So we're kind of screening for potential hallucinations, auditory or visual, or, like loss of orientation of time, which is number 8. That's different than perceptual disturbances, but it's just sort of leads to a different kind of neurological understanding of what might be going on here. Thought dysfunctions, specific dysfunctions, is when you think of like cognitive therapy, like catastrophizing and that kind of stuff, or sort of not tracking sentences, that kind of thing. Orientation. What we're talking about here is orientation. That word sounded funny when I said it there for a second. Orientation to time, self, and place. There's always a fourth one that I forget, but do they know what year it is, what time it is? Do they know where they are in the earth? And then do they understand who they are, their identity of themselves, that kind of thing. And then memory, concentration, attention. So we'll get back to that. I'll give you more specifics on what that looks like and how it's done. But if we get information in all these categories, it can quickly help us glean a whole bunch of information that can be helpful, specifically if we're watching people from day to day. Those of you that might be working in agencies, like or inpatient units specifically, you're going to see a lot more of this than if you're doing outpatient therapy. But it can be really helpful just to jot down a few things related to this in your notes, because if someone comes in and you're like, I don't write it down, but I noticed that they came in and then 4 sessions later, they're really, they sit up a little taller and their shoulders are back a little further and they just seem to have more of a bright affect. That can, looking back on your notes from a quick MMSE, can say like, well, I'm seeing progress here. So capturing a little bit of this, even if it's an abbreviated version, can be really helpful. Okay, just gonna check where we are. This is the last slide, so we're doing good. Specifically this term neuropsychological evaluation or assessment. I'm going to also throw out the other term of psychological assessment. we have to be careful of these terms. For one, we are counselors and we don't do a psychological assessment. And yet, remember when we talked at the very beginning about the politics and some of the politics of assessment? One of the terms that you may or may not have heard before is identity. Wait, what is the term? Blanking on it now. By the way, I'm recording this in the middle of our spring break, and I just got back from my little mini vacation, so I think my brain is ramping up a little bit already. What is the phrase that I'm thinking of? Crap, this is embarrassing whenever this happens. But also, by the way, a little quick side note: whenever I have something like this that shows up in a lecture, I feel a sense of embarrassment, but I also think it's important for us as counselors, and I'll start with myself, to model that we experience emotions that are uncomfortable and that we would like to gloss over or edit out. And it's also very important to show people that we experience these things. So oftentimes I hear from you guys as students that it's comforting to see all the good, some of the good and some of the bad parts about our professors too. Some of the humility that says I'm not perfect. That's kind of why I leave this stuff in here, because embarrassment is nothing to be afraid of, and yet we avoid it like the plague most of the time and try and avoid embarrassment at all costs. But it is a normal human emotion, and it's okay to have it. It's just really important what we do with it. If we fight or flight from the experience, then it's not super helpful, right? So anyway, I'm going to explain what the term is, and it might come to me as I'm talking. But what we're talking about here is, for example, when I was in Montana, I worked relatively closely with the National Association of Social Workers, or at least the Montana chapter, because they had more of a presence in Montana. The counselors didn't really have a professional organization, so we worked together to do trainings and that kind of stuff. They really care a lot about who gets to call themselves social workers and who doesn't. This comes up in our counseling world quite a bit because of, and I really don't want to throw any shade towards other practices or professions, but I'm just sort of repeating this, not my opinion, but I'm repeating it, that people who use terms like I'm an art therapist, or because art therapy is trying to achieve licensure in several states as a separate practice that needs to be regulated, or life coaches. Some people say, well, I don't need to have a counseling license. I'm not doing counseling. I'm a life coach. So I won't talk to people about their potential diagnoses, but I will do all the same activities that counseling does, which is be supportive, talk people through some of their issues, that kind of stuff. So there's this political tension, I guess, for the lack of a better word, between people who are doing counseling like things and people who aren't. Same thing with social workers. When I used to work, they protected their identity by saying, if you don't have these specific degrees or these licenses, you can't use this term. And it basically protects that term as a sort of important, almost kind of sacred thing. The reason I bring all of that up and explain those things is because terms like psychological assessment, it's so ubiquitous, and it's so much a part of our pop culture common lexicon to say psychological assessment as a synonym for like mental understanding or psyche evaluation or something like that, that it's not a protected term. So some of you might use the term psychological assessment or psychology, but we need to be a little bit careful with that and how we talk about it with clients, because psychological, or especially neuropsychological assessment, there is a kind of a specific way that gets used, and we don't get to do that because of our level of training. So this goes back to our understanding of competence. You'll hear me say in multiple different times and places, kind of out of both sides of my mouth, that we have the training and capacity to do a lot more assessment than what many counselors believe. On the other side of my mouth, I'll say we have to be very careful about what the ethical scope is of what we're trained in and what our experience has trained us to do. That's a very gray, difficult conversation to have, and we can do that in class if we need to. But when it comes to neuropsychological assessment, what we're really talking about are very deep, complicated dives into what is going on in a person, often involving intelligence assessments at these levels, level C assessment levels. We need to be very careful. If you don't, I'll try to show you in class a little kind of a snapshot of what these assessments look like and where we need to be how they're dangerous. It's like picking up, what's a good analogy? When I grew up in a hunting family and I grew up around rifles. And so I can pick up a rifle and kind of understand how to respectfully and safely use that gun. But an assault rifle with a hairpin trigger and, somebody shaved off the, whatever you call it, shaved down the trigger so it becomes not a semi-automatic, but an automatic. That is a weapon that I should not be handling, right? Or like if I picked up a bazooka, I'd be the guy who faces it backwards and shoots the truck behind me or something like that, And the point that I'm trying to make is that not all weapons are created equal. Not all assessments are created equal. And the bazooka versus the handgun or the, hunting rifle, they can do a whole different level of damage. And so we need to be really careful about what we can do. Again, on the same token, we also need to have the confidence and because we have the responsibility, we have to have the confidence to perform at up to a certain level and not above and not below. So we got to find that sweet spot while you're in school and beyond. So don't do neuropsychological assessments. That's the gist of it. Don't tell people you're doing psychological assessments because you're probably not. We can talk about what specifically those mean a little bit more. But often they consist of a battery of tests, which means just several tests put together. And the purpose is, I'm going to use this kind of big wordy definition here, but we want to assess biological conditions, electrical, kind of neurological conditions, chemical conditions, which we don't really assess for at all, and psychological dysfunction. We're trying to, with a neuropsychological evaluation, you're taking a much wider swath of training and experience to get more information about a person's biology, chemical insides, different physical conditions, as well as mental conditions. We just don't do that in our therapeutic spaces. Some of you may be trained to work within that environment, but you're probably not performing those kind of assessments. Where we focus more is our specialty is more, maybe I shouldn't even go into this because I'm going to tell you something, but it's not really going to capture the whole picture. But by and large, a lot of what we're doing with clinical assessment is we're understanding diagnoses. And I'm not going to say which ones because there are some that I would stay away from as a counseling profession, specifically neurological disorders. And for many of you, childhood disorders, unless you get special training in that. And sometimes personality disorders. We can venture into some personality disorders, but sometimes we need some extra help and referral out to other resources too. But with that said, oftentimes what we're doing is understanding social, emotional, and interpersonal conditions. We don't need to be experts in biological conditions. We don't need to know all about, neurochemical things that are going on inside the brain. When people come to us and say, I feel bad, I have this relationship, that's where we really can explain a lot more and help people understand how to work through those kinds of more wellness model common conditions that people experience. So, what we're talking about up here, social, that's our territory. Interpersonal, that's our territory. Situational, like life stage kind of things based on understanding of human development, lifespan development, versus physiological conditions. If there's something more, what we might think of as medical sometimes, or physical, all this stuff above, bioelectrical, chemical, that kind of stuff, that's where we're neuropsychological assessments trying to capture all of those things. Okay. So anyway, hopefully that lecture is enough to scare you into being more responsible, but not so much that you're, in defense mode or something. It should bring up more questions than answers. That's the point of it, so that we can talk about that more and you can get information from other people, not just me too. So anyway, that's it. So I'm going to stop it there and then I'm going to jump over, and I apologize. This is going to be a little bit longer than an hour for most of you that are used to spending only an hour, but hopefully I will make it worth it. Shouldn't be more than like 20 minutes or something. But anyway, see ya.